Good day, everyone. Thank you for joining us today. We have with us Dr. TAUFIQ Benjamin from Gold Coast in Australia. He's been one of our speakers at the Prism Academy conference, first integrative medical conference, and we have learned so much from him. So we thought it's appropriate that we introduce him to our viewers. Good morning, Dr. TAUFIQ.
Good morning, Dr. Karthik. Thank you for having me. Thank you for inviting me to this amazing venue and conference, meeting amazing people here. Thank you so much.
Yes, we get to learn so much from so many people practicing across the world, and hence we even tend to develop our own practice by this means. And I see from your degrees that you actually worked across continents. And are you able to share your journey, how it started, your basic medical qualification, and then how you ended up where you are today in the integrative space, the cancer space?
So I was trained I did my basic medical degree in University of Leeds in the UK after I finished high school in Malaysia. Sorry, after I finished college in Malaysia, I did my high school in Brunei. So I did 5 years medical degree in University of Leeds in Yorkshire, and at that time I wanted to train to become a surgeon. So after that, I enrolled into the surgical training program to do orthopedics. But unfortunately, at the time, there's a change in terms of the medical training scheme. So then we got caught out. So I had to change specialty to do general practice or family medicine. So I enrolled into a family medicine training program in the UK. And because my wife, she's from Canada, so the plan was at the end of that training program, once I qualified as a family medicine specialist, was to work in Canada. So I did all the exams, the paperwork for Canadian PR, for example, to do that. And then, unfortunately, during that training program, I got severely ill with a Guillain-Barré type syndrome, which affected my autonomic nervous system. So I've been I had severe tachycardia. The first one was about up to 200 beats per minute. So I have felt, chest pain, where you have basically hypoxic uh, cardiac,
Right.
because the heart rate went up to 200. So because it's so fast, there's no oxygen into the heart. I felt my arms becoming tight, my chest becoming tight.
Almost like a coronary syndrome.
It's almost a pre-arrest, basically pre-arrest. So at that point, as in that process, I told my wife to call the ambulance, obviously, and went to a meditative state. Because obviously, if you panic in that situation, you have more adrenaline, and then who knows what happens. So I went to a meditative state, and then my heart rate started to come down. So when the ambulance arrived, actually the ECG was 160. Oh. That's already better. And I was really sick. After that, I went to the coronary care unit, unfortunately, even though I was working in the hospital there's no beds. It wasn't in winter.
It's the typical
NHS. I was in the corridor, even though that's the hospital I was working in. And so the cardiologist there, I knew everybody because they're all my work colleagues. And yeah, so I saw 5, and that week I was really, really sick. My heart rate kept going to 150, 180.
Huge fluctuations then.
Massive, And then, so I saw 5 cardiologists in the end. They did all sorts of tests. Initially, we thought it was kind of like viral myocarditis. It's in the winter. I wasn't really sure, but none of the tests, troponin was normal and stuff. There's nothing to suggest it's actually myocarditis.
Right.
So we wasn't sure, but I was still not well. After that, I had more symptoms like fatigue. My muscles start twitching everywhere, and have symptoms of hypersympathetic, symptoms like sweats, anxiety, all these other things. And then I started seeing more nerve issues, symptoms. My left pupil blew up larger than my right pupil.
Right.
In the mirror, oh, that's not good. That doesn't look normal.
A lot of complications following. What was this following? Was it a viral
So
infection?
at the time, we didn't know, So then because of that, my GP trainer sent me to his colleague who's like a good neurologist,
Right.
you know. So obviously you need an MRI scan. So I did MRI scans.
Hurt the pupils.
Yeah, like that doesn't look good normally. So I did MRI scan, did EEGs, did the nerve conduction studies and stuff. It is luckily the MRI was normal, which is what I'm grateful for. And then he took a history, did so much blood tests, and he was the one actually the neurologist said, based on the history of what happened, he thought it was the vaccine.
Right.
It was the flu vaccine that I had 3 weeks before, because I told him like had started with like ectopics, like just like beats, skip beats, like my heart feel like it skip, and then got worse and worse.
So was it the first flu vaccine which you ever took?
No, I had flu vaccines before, but I think it was the first one that had the H1N1 in it.
So the quadrivalent vaccine.
A trivalent at the time.
Trivalent, all right, okay.
I think the first trivalent one.
Okay.
So I think I had and he was the one that said
Right.
that is probably that triggered it, you know, that caused like kind of like Guillain-Barré type nerve damage, you know. But even though he kind of like working out what's wrong, there's, as you know, there's no treatments for it, right? So I was still having severe palpitations, and then I have nerve issues, damage, and like neuropathy, burning in my legs, and you know, fatigue. And I was still doing the exam at the time for the Royal College for GPs. And just before the exam, the night before the exam, I had an episode where I had a severe tachycardia. I was like, you know, so I went to the exam and I said, if I pass out, just call the ambulance. Don't try to like do anything, just because there's no. Then they go over it, so you better like go back home and come back when you're feeling better. So, and I was in actually in the role, the GP examiners was in Croydon, right? I think.
Okay.
Yeah.
Yes, it was.
It was in Croydon, the building Croydon. And next to it is like a Chinese supermarket, and which we always used to go to. And next to it is like a Chinese doctor practitioner who claimed to be a professor from China or something.
Okay.
And then by that time, I've seen like 5 cardiologists. I've seen 2 specialist neurologists, and none of them could actually help me. So I thought, why not? Why don't I just go to Chinese medicine, right? So he did acupuncture, right? And for the first time in that 6 months of being unwell, like, actually my heart rate come down. I felt better, you know. And I told him I have an exam in 3 days to repeat the exam, right? Because if I fail the exam or I miss the exam, I have to wait another 6 months.
Yes.
So I need to feel better, you know. So then I had another 3 days later another round of acupuncture.
Okay, before the exam.
Before the exam,
Okay.
and my heart rate was stable.
Okay, good.
Was good, you know. And then I did 6 weeks of acupuncture plus herbal medicine.
Okay.
With that guy, and the palpitations stopped.
Oh, fantastic.
Yeah, it was amazing. You know, it was good. And so I passed the exams.
Okay.
And as the plan initially was to go to Canada, so I went to Canada. But during the testing, multiple tests, one of the tests that we did, my vitamin D level was so low, it was undetectable, was less than 5. Because you know, as you've been in England, it's just grey and rain, and you wear like jackets and stuff. It is, you know, and how vitamin D is so important.
Yes.
And perhaps I had vaccines before, which I never had any. You know, as doctors, we have so much vaccines for studies, for exams, hepatitis, everything, right, to good degrees. I never had any issues.
Flu is mandatory there for frontline workers.
At that time, I had flu vaccines before. I never had any issues, right?
No, what I'm saying is the amount of vaccines what we as frontline health workers, as doctors, we take. In that, even there is that flu vaccine yearly is actually a mandatory one. They ask us to have it. They make sure.
But for me, it was the first time that had the H1N1 incorporated
strain
into it, you know. But before, I never had any issues with vaccine. But maybe it's just a combination of like really bad vitamin D levels at the time, you know, as well. But basically, because of that, then I thought working in.
It's such an important vitamin, underrated vitamin. And
Correct.
So important to have the levels. And levels also, the lab values, what they give us is between 30 and 100. But, you know, in my patients, I always maintain it 100 and above, as if possible, you know, or closer to 100.
Just to to complement what you're saying, just break off topic a bit. I did a clinical trial for COVID patients, acute COVID in 2021. We treated 237 patients with acute COVID, severe COVID. I'm talking about the age group was between 22 to 99,
Okay.
and 70% had comorbidities, heart disease, diabetes, and lung disease, right? So this is typical, and they were in ICU stuff. So our treatment protocol was hydroxychloroquine, azithromycin, but vitamin D, and IV vitamin C. So we did two groups. One had the cocktail,
Okay.
but one had intravenous vitamin C, and one didn't have intravenous vitamin C.
All right. Okay.
So we treated 237 patients in 6 hospitals in Turkey.
Okay. In
Turkey.
Turkey.
Yeah, because at the time in Australia, there was no patients for COVID.
Okay.
It wasn't a thing in Australia.
Okay.
So we got Turkey, but this whole COVID has been a lot of politics.
Yes.
So many hospitals, when they mentioned hydroxychloroquine, as much they rejected in outright.
Yes.
But Turkey managed to accept to do this trial.
Excellent.
So out of 237 patients
Right.
that got COVID in hospital,
Mhm.
really sick,
Right.
only one died.
In
Only
both
one.
the arms of the trial.
Yeah, only
Okay.
one death, and she had the lowest level of vitamin D.
All right. Okay.
And we looked at everyone who got admitted into the trial, they all had less than 75. So meaning anyone above 75 levels of units of vitamin D in the blood don't end up in hospital.
Okay.
And we did a correlation between vitamin D and severity and the stay in ICU. The lower your levels of vitamin D, the more you stay in hospital, and the more you end up in ICU.
Okay.
That's a very strong correlation. And vitamin C intravenously, the ones who had IV vitamin C, less than 15 days in hospital. The one without IV vitamin C, and more than that, up to 45 days in hospital.
Okay.
Compare this to standard care, in this patients group, the mortality is 1 in 6.
Okay.
17%. In our treatment protocol, mortality is 0.4%.
Wow.
But
both wings.
yeah, in both wings, like total, yeah.
Total.
Yeah.
Fantastic.
So we did know how to treat acute, severe COVID at the time, but people still reject. That's clear data. But anyway, going back to my vitamin D levels.
Yes.
So I think that's why I end up with nerve damage at the time. So I thought Canada is like UK, is a bit grey, it's a bit cold. Yeah. So that's why I end up I thought Australia would be a good option. There's more sunlight, So I applied to Australia, got a job there in New South Wales, in Central Coast, as a GP. So worked there for 5 years. I did a lot of skin cancer work. But in that journey, because I had all these nerve issues still, that's led me to learn more about integrative medicine. And the good thing, I suppose, in Australia, there's colleges like ACNEM, like the Australian College of Nutrition and Environmental Medicine, which I joined, and so I learned a lot of basics at the time there, and there's functional medicine, so there's a lot of the different options there, which opened my eyes, and because of my experience as well. So I learned.
ACNEM is a very active organization.
Yeah, correct. Yeah. So
that's probably the only one, the Australasian, what is it, the full form it's called?
ACNEM is Australasian College of Nutrition and Environmental Medicine.
Yes.
Yeah.
And is there any other thing similar to that in Australia?
Also AMA, Australian, I think it's Integrative Medicine Association. AMA, also good. They're trying to do like a board certification for integrative doctors there as well. So that's also good. So I mean, I got learned, took courses from there and stuff, and also did a lot of things to help to get myself better.
Okay.
Because I think at that time, I also got some of my symptoms back when I removed an amalgam without proper protection.
Right.
So I get more nerve damage, unfortunately, from there. So I got the palpitations, the nerve issues back.
Right.
So then also learning how to remove heavy metal toxicity from myself and reverse the nerve, because I had dysphagia, I had swallowing problems.
After the removal of that.
Yeah. Because in one of the tests that I did, as to find out from the first episode, I had a bit high mercury levels and had an amalgam, so I wanted to remove it. But this was before I knew more about biological dentistry, where they took extra precautions, and I didn't know anything, and the dentist obviously didn't know much as well. So I ended up with severe nerve. My face muscles got paralyzed here. I got swallowing issues. I got proprioception issues. Yeah.
So you textbook case of a lot of these things.
Yes.
Vaccine related
Yeah,
issues
and heavy metal toxicity and all this thing, yeah, and nerve damage, neuropathies and stuff like this, you know, palpitations,
Right.
fatigue.
And how did you offload the heavy metals from your system?
Oh, the best, you know, I tried a lot of things. The best I find is actually wet cupping hijama. One of the best is
Wet cupping.
yeah, wet cupping hijama. That's one of the best treatments I've had that reverse a lot of the nerve issues.
What happens in wet cupping? What do they?
So cupping is just putting negative pressure in the cup, but
Yeah.
wet cupping is like you do the same thing for 5 minutes, remove it, and then either take a scalpel, like blade or needles.
Okay.
I mean, it's not stab wounds, right? It's just like paper cuts,
Okay.
tiny slits, right? And then put it back, and then it draws up blood and toxins and poison from that area. And you do it on certain acupuncture points and over certain specific organs,
The back.
on the back, on the front, on the head. You know,
Okay.
because with I had vertigo, I had tinnitus.
Okay.
You know, I had dysphagia. So I did a lot from the vestibular area at the back, you know, at the neck as well,
Okay.
and the heart because I had palpitations come back, and legs. My legs were like weak and you know at the time. So I did a lot of that to recover.
Okay. What other things you tried for heavy metal detoxification?
The best I find. So when I went to learn about hypothermia in Germany, hyperthermia in Germany, Dr. Sahimbas, he's the president of the German Hypothermia Society. So I did some training with him.
Okay.
And he said one of the best things at releasing heavy metals, toxins in the body is heat, is hypothermia.
Okay.
So when you heat up your body, your rate of release of heavy metals, mercury and stuff, is like it's like 4 or 5 times more, right? So that's one. And also then when you release, you need to bind it. So like people use like DMSA or all these things. I use like a nano zeolite.
A zeolite, yes.
Yeah, but a nanoparticle type.
In a spray form.
A spray form, yeah.
Okay.
So when I tried one time, I took like there's 2 brands. The first brand was quite expensive. Then I found a second brand that's half the price.
Okay.
So I went a bit crazy with the spray. This is not spray just because it's cheap. And then I had like for a few days I had word loss issues. I had like
what loss?
Word loss, meaning like I want to say something, but I just cannot find the right words. Like let's say I want to say a pen. I said maybe like a writing instrument. It just wouldn't come out.
Why?
It's the heavy metals, the mercury, you know. I got proprioception. Like the proprioception is a funny thing. It's like you don't like you're twiddling your thumbs, right? You don't even think about it. You know your thumb is there, right? It's just like a
by default.
By default, right? Because proprioception has the biggest nerves, the A-type fibers, the fastest fibers.
Yes.
So at every point of your joints, there's proprioception receptors. So it creates a 3D image in your brain in real time to know where your limbs, fingers are, so you don't trip, you don't fall, right? You don't. But when your proprioception fibers get damaged with the myelin sheath, right? There's a slight delay. Even that slight delay of data signal into your brain, you don't know where your hands are.
So, oh my God.
You know, it's like for me, like to move my hand, like where's my hands? Like I have to like think about it. For a millisecond, which seems like a long time to move your hands. It's just a very odd feeling, but that's what I had.
And that's one of the classic of mercury toxicity.
Yeah, but that's what I experienced as well, right? Proprioception is then nerve pain and all those things. So when I use that a lot, it kind of like in a way pulls it too much, too quick, too harsh, that it feels uncomfortable. Mainly because the word loss. When we see patients, it doesn't look good if I want to tell them something and I cannot find the word to say it. It's not good, right? So I think even with detox, you have to do it slowly.
Yes.
So then for me, I find that I can't take the spray too much, you know, because I suffer for like 4 or 5 days. It gets better after 4 days. It back to normal, right? But so I do a sauna, for example, and then I just maybe take 2 sprays.
Okay. So the FAR sauna is good as a heat modality.
Yeah. So I do that and then to take 2 sprays and keep doing that, and then eventually it comes out gently, comfortably, you know, that I can take multiple sprays without having flare up of the nerve issues.
And how often you used to do the FAR saunas?
Oh, I think because they're all busy, right? Sometimes only do it once a week. But one time recently had like some vertigo issues.
Right.
I did like 4 times a week.
Okay.
but after that, that stopped. Because I know that when I have these issues, somehow that's like related to like heavy metals.
Slowly, the better way to do it is slowly but surely.
Yeah, because it's just you can't do it fast, quickly, but you have to be mindful. You have to bind it. You have to like monitor the symptoms. You can overwhelm the drainage
Yes,
systems.
because it gets clogged.
It gets
Because
clogs, correct? Yeah, and you also shake the organs too much. Like in my situation, the brain, the even my limbs, all these nervous issues get shaken too much. So that's why I try to do it for myself gently. But that also applies to my patients, right? Because they also have to speak to others and do stuff. So I suppose, I mean, when experience is your best teacher,
Yes.
in a way, that's your number one teacher. Number two teacher is your patients. I learn a lot from the patients as well, what they report, because everyone's different. So in that sense. So I mean, so this is how I suppose I end up into the integrative space by being your own,
Yeah. What supplements along the lines have you taken, and what are you taking currently before we move on to the next topic?
As you know, because when you get ill, you take a million kind of supplements, right? So much supplements. But I think these days,
Which one has helped you the most, and what are you currently on?
I always believe that food over pills is better. I was,
Yes.
but so in part of my recovery, I followed the Terry Wall's protocol. She did a diet specifically for patients with MS. I mean, I didn't have MS, but I did have like nerve damage.
Yeah.
In the like in the nerve conduction studies, it shows that I have damage with the demyelination, because the speed of conductivity dropped. So that's myelin damage, which is like similar in like kind of MS, right? So the diet specifically to help rebuild your nerves and rebuild myelin. So I went on like a strict paleo keto diet.
Okay, and this is whose diet is this?
Terry Walls.
Terry Walls.
Yeah.
Yes, she's the
Yeah.
one who's written a book on.
Yeah, Terry Walls protocol, because she has MS.
Mm.
She was in a wheelchair for 4 years. She had MS for 14 years.
Right.
And it was secondary progressive, which nothing, she was getting worse. But after doing this protocol, she went to cycling 18 miles in 10 months, right? Amazing. So I think diet is thing. But in terms of supplements, like I said, I think for myself, right? Especially in the context of Australia, the soil in Australia is poorly mineralized for food. It's good for mining, but for agriculture, we have lack of magnesium, we have like selenium, lack of trace elements. So I have patients that they go to like New Zealand or to Bali, live there for a month, 6 months. Their immune cells from low, being red like abnormal, to normal in 6 months. Nothing changed. Just eating food grown in soil that has a lot of minerals, right? And then when they come back, it drops again. So in a sense, that's a supplement that I would recommend for myself in Australia for patients, like trace minerals.
Yes.
They call fulvic acid or something like that, which are trace elements, basic trace minerals, like magnesium or like selenium. I take a lot of selenium. I take vitamin D because I'm still, even though I'm in Australia, it's sunnier than UK, but I'm still in the office, in the clinic, seeing patients. Yeah, closed spaces. I'm not in direct sunlight. And because I take high levels of vitamin D in the morning, I take K2 at night.
They work well together.
They work well together, but they cannot be taken together because they're both fat soluble vitamins. They'll compete, and then vitamin D wins out. So then you lack vitamin K2. K2 is needed for like calcium management, in a sense, to get your calcium into your bones. So I take most like selenium or minerals and vitamin D, and that's it really. Yeah, because I try to eat healthy first, right? Like food full of nutrition initially. Yeah.
So good. That's how you ended up in the integrative space.
Yeah, that's I mean negative space through experience.
So what does your day typically look like in Australia? What is the composition of your OP day or your day itself? The kind of patients who you're seeing these days.
I mean, these days, because of the massive surge in cancer patients, like in the last 3 years, right? So unfortunately, I mostly see cancer patients, and a lot of them are stage 4. I mostly actually see stage 4 cancer patients, because of that. We have another doctor that joined us recently. So he sees the like stage 3, stage 2, stage 1.
Right.
patients. I see mostly stage 4 patients, like from 10 to 10
Okay.
or 11 to 11.
Okay.
Yeah.
So what happens? How do you sort of manage these patients? Or I mean, if you say stage 4, they would have already had all the diagnosis, the
Correct.
investigations done, and
All
they would
done.
have
Yeah.
a diagnosis and biopsy, and everything would be
Done.
almost
Yeah.
there.
Correct.
So how do we manage these patients?
So yeah, correct. Like the patients come to me already have their diagnosis. So I'm not like in a sense I'm not really working as a primary care practitioner where I have to make the diagnosis or
Yes.
send a specialist. These patients already have their diagnosis well confirmed and already sometimes seen other specialists, oncologists. So I think what they come to me for is like to find out any other ways to help to the standard care approach or treatment better or less side effects or better efficacy. And that's what I feel our job is.
Okay.
But so it starts with education, like any patients, right? So I go through that similar to the slides that we talk about in the conference about what cancer is. I think it always starts with better understanding what is cancer and how they got, because that's the first question. The question they always like, doctor, why did I get cancer, right? And unfortunately, most of the time, doctors tell them it's just bad luck. And I think that answer really deflates them a lot, like because a lot of them, some of them, it's not like most of our patients are not like Coca-Cola drinking, McDonald's eating, overweight patients, right? So those patients, maybe they already like work it out, maybe it's bad lifestyle or bad diet or smokers, right? These patients are healthy, they've always been eating organic foods and slim, exercise, and then bang, stage 4. So obviously the first question you ask, doctor, like, why? Why? Like, meaning like, if they get cleared, what do I do, right, to prevent it happening again? Because I've done all the right things, I still end up with this. And how do I prevent it if I get it back? God forbid, right? And suggesting, okay, you're just unlucky, I don't think is good enough, right?
That's not a good
Yeah,
answer.
yeah. Why do you get, and especially if you observe it's getting worse and more patients, getting unlucky, what? Get the horseshoe and the rabbit's foot to prevent yourself. And so it starts with education, understanding like, right, there are environmental factors, and they also know, a lot of them tell me like they have some form of psycho-emotional trauma. Not everybody, but I would say maybe 90%.
And
They know that. Yeah.
do you a person to deal with that aspect in your team?
We used to have a psychologist that did the EFT, but she's moved on. We need to find someone else because that's an important factor, very important factor.
Part of the team as
Correct.
well, for them to decode that element and keep
Exactly right. Because they always tell, when you go to that field, they said I knew it. I had a feeling that either like the divorce or someone died, some bad, their business went bankrupt or something. There's a massive trigger, psycho-emotional trigger.
about 6 months or
Yes,
something.
normally like a year to 2 years.
Year to 2 years,
Depending on, obviously with this COVID situation is quicker.
Yes.
But in the past it's like a year to 2 years, and they knew it because obviously for them to get to stage 4 it's not overnight. It takes about a year to 2 years to get there, right?
And when you say COVID situation, post-pandemic and post-COVID illness, we have seen an explosion in a variety of
Cancers,
cancers, a variety of a lot of common things, autoimmune, abscesses, diabetics, chronic, and I'm sure that is reflected in the
cancer population. Yeah, actually, because one of the things, like some of my patients who caught COVID, for example, their CD4, because we check lymphocyte levels, and CD4 T cells drop. I mean, like similar to HIV, right? I mean, I don't see much of the viruses that drop your CD4 T cells. So we often see this when you do a lymphocyte subset test. You see that dropping. So basically, immune system dropped. So then you're prone to other infections. But there's also a lot of spike proteins activate certain things, and the virus itself changes the genetic expression of the tumor cells to make it more like sugar loving, but more highly active in terms of glycolysis. So that's why, unfortunately, we see like massive growth in the tumors in patients, unfortunately. So that's how, I mean, there's so much patients. Just the waiting list, unfortunately, can be quite extended. But the way I set up my day is that, especially for new patients, because partly, I think the important part is education.
Mhm.
So I have like a nurse who, and also I make the videos for them to watch, and the nurse to see them first to educate them. Because if I used to do it all myself, right? But I find a lot of stuff that I tell to each patient is the same in the beginning, a bit repetitive, you know. So then I was thinking like maybe I can just condense it into like a video, and also the nurse can also go through the framework of what we do. So at least gives them that introduction into what we do. And then after that, we do some blood tests to see, to personalize the management, of course. And then we see them. And then I see them and then go through, because there'll be other things that maybe the perhaps oncologists don't really look at
Yes.
in terms of optimizing the patient's
That's true.
overall like health and wellness, right? So let's say they're deficient in vitamin D, we boost it up. For example, if they're low immune system, we push it up. For example, I need anything else. So we go check on that background levels to support it, and also then refer them to like psychology or something like that to help to like, because they have obviously they have a lot of stress, there are a lot of fear, and as you know, these things doesn't help in terms of any condition, especially cancer, right? So you need to understand how this impacted and to understand the detox, you know. And then we start with like blocking to help the standard care treatments work even better. We try to like block the metabolic pathways, so to stop the sugar access to the cancer cells, the glutamine access, the fat cells, and we have seen amazing results. You know, patients stage 4 who are not expected to do. I mean, normally they just like, let's say they take ribociclib, like a CDK4 inhibitor, right? For example, in stage 4 breast cancer patient with bone mets, you know, they're expected to like maybe just stable disease is a good response. They're not expected to go into remission. Combined with other treatments, for example, they've gone to remission in 3 months, for example. You know,
So when you say other treatments, I'm assuming it includes vitamin C and intravenous vitamin C.
not always.
Right.
Sometimes depends how everyone's different, depending on how, where they are. Because I also see a lot of like interstate patients,
Okay.
or you know, telehealth patients. They are far away, kind of thing.
Okay.
If they are local, they have potentially can do IVs and stuff. It is.
Okay.
I do a lot more IVs in terms of like supporting patients undergoing standard therapies like
Okay.
chemotherapy and other stuff, in terms of detoxing, in terms of like boosting the vitamin C levels, for example. We use a lot of glutathione to just to flush all the toxins out afterwards. I mean, there's a lot of fear about glutathione, for example,
Yes.
but there's a lot of randomized clinical trials, placebo-controlled clinical trials, where they actually, in the 80s, where they actually use glutathione with chemotherapy.
Okay.
Right? They use anywhere between 3 to 6 grams of glutathione.
That's a lot, no?
Yeah, a lot. Yeah. They either give it just before the day before chemotherapy. They did 2 groups, so
Okay.
control trial, right?
Okay.
One group had standard chemo cisplatin, for example, with glutathione at 3 gram per meter square, which is roughly about, if you're about standard height and weight, it translates to about 4 to 6 grams of IV glutathione. Yeah.
Yes.
And one group just placebo, right? And you can see in after 6 rounds of chemotherapy, you know, the group with the glutathione had negative 39% of symptoms of like brain fog, nerve issues, hair loss, you know, depression, anxiety, vomiting, whereas placebo control had positive 60% side effects.
All right. Okay.
And then the worry is that people say, oh, the glutathione will stop the chemotherapy from working, right? Because it's an antioxidant.
And
The data showed that with the glutathione, that 73% response, positive response with the chemo, whereas with the placebo, 62% response.
73% positive response.
Yeah, versus placebo, 62%.
Okay.
So meaning the glutathione did not stop the chemo from working.
In fact, it was.
In fact, it's better, right?
Better.
Yeah, because also you think that if the patient's not vomiting as much, less fatigue, less nerve issues, they can proceed with the treatment better than if you have a lot of side effects, you know? So there's a few randomized controlled trials that say the same thing. So the reason is what people don't understand is that they're confused with the glutathione data is that number one, intravenous glutathione doesn't cross the cell membranes. There's no membrane transporter for glutathione. So intravenous glutathione cannot cross cell membranes to salvage the cancer cells from the chemotherapy. Okay. Number one. So it just mops up the toxins in the outside, in the extracellular fluid, in that sense. And number two, the glutathione that protects cancer cells is actually the glutathione that cancer cells themselves make their own. Cancer cells make tons of glutathione internally. So when the poison comes in, they just neutralize the poison and check it out. So that's and that's true. You can see a lot of studies where glutathione helps.
So it's outside glutathione which needs to be increased.
Correct. Yeah.
We can do it through our
correct. And then strategies to decrease the intracellular glutathione in cancer cells, for example, using high dose selenite to pre-treatment before cytotoxic agents, so that to stop their own internal production, so that they are more vulnerable to like other agents.
So the other chemotherapeutic agents.
Yeah. So that's why we give, like, for example, intravenous like selenite, sodium selenite. Or you can also use curcumin, like intravenous curcumin, because there's also ABCG pumps where the poison comes in, the cells can pump it out. So they never get into a dose that's toxic enough. So we can use curcumin to block that as well.
Curcumin, does oral nano curcumin have the same effect as intravenous curcumin, or
if it's liposomal, potentially, yeah, because just curcumin as a powder form, it's only 1% bioavailable. Right. If you add, and people say, oh, I think pepper increased by 100%. It is true 100%, but it's from 1% to 2%. That's 100% increase, right? But it's just marketing.
Right.
So 1% to 2%. It is 100% increase, but it's not a lot, But liposomal is up to 30% bioavailable. But of course, like intravenous is like 100% into the blood, right?
Go straight in. Because we have difficulty with IV curcumin in India. Availability is a big issue.
Yeah, so we get ours from Germany.
Right.
Yeah, but at least liposomal is a good option. Before chemotherapy, for example, or cytotoxic therapies, to block the ABCG pumps. And plus it's anti-inflammatory and so much other pathways of working, right? Yeah. So it's good. Yeah.
So they undergo these things for a period of few months.
Yeah. No, sometimes concurrently, like before chemotherapy, like the day before we give selenium or curcumin, then there's a die off the tumor, then they typically feel nauseous on day 2, day 3, right? But that's when because the chemotherapy stays for 2-3 days, for example, and that's where they don't get nauseous on the first day. They got nauseous on the second or third day, the fatigue, right? When the accumulation of the toxic debris from the dead cells, that's where you need to clean out, So that's why we give like glutathione then to flush it out, or also use hypothermia to like infuse the tumors with the chemotherapy to make it more effective. And hypothermia has been shown to double the effectiveness of standard care chemotherapy by to like 100%, to double the effectiveness, right? So we do that as well.
So hypothermia, do you have hypothermia machines for the local and regional and whole body hypothermia?
Correct. Yeah, we used to have the Haeckel. We have the Haeckel hypothermia, the whole body hypothermia. We used to have the Celsius, the local hypothermia. But that machine's not working anymore. We're trying to like get one more, and a local machine from Korea. There's remission 1 degree. I mean, I just came back from a conference and a trip to Korea. Amazing what they're doing there. They're so far ahead.
In terms of anti-cancer and in terms of the adjuvant therapies, what they're doing.
The number one difference, and because I've been to Switzerland and Germany looking at the clinics and stuff, the number one thing is funding. Funding for integrative medicine, right? It's expensive. The insurance doesn't cover it, and the government doesn't cover it, right? So hypothermia or IVs, that's mainly the barrier for entry for a lot of patients. In Korea, though, the insurance and the government funds it. I mean, that's just amazing.
It makes sense, because instead of spending 100,000 for your, let's say $100,000 for your treatment with chemo drugs, you probably get at a tenth or a fifth of the cost. Even your integrative treatments are a little bit less expensive compared to the chemo medicines. What you're
yeah, but the main thing is, like, I think perhaps certain insurance companies sees the value in it. Because not so much from that, but let's say integrative treatments cost $100,000, for example, right? Let's say if they die, and most of these patients are young, right? The insurance company have to pay out, like, say, $1 million. Right? If they die, they have to pay out $1 million, right? 100,000 is still cheaper than a million.
Million.
So if you're able to like hopefully help them, save them from like dying, for example, combining all the different therapies, that is still cheaper for the insurance company to pay. So I think they see that advantage and they fund it, right?
Because they're well funded, you probably have more integrative clinics doing a lot.
Correct. That's what I'm saying. Yeah, I think they're 20 years ahead in that sense. One of the clinics, we have like 20 hypothermia machines in one clinic, one hospital. Crazy, right? And I was asking, like, how can you afford all this? Because one machine costs $20,000, 20 machines cost like 60 million. Like, how can you afford? It's because these patients are paid by private insurance, by government, so they have a lot more patients with a lot better results because they're combining this with radiation or chemotherapy or immunotherapy. Especially immunotherapy, it gives amazing results because hypothermia modulates the immune system to target the tumor, especially combined immunotherapy using like stage 4 patients going to remission. So that helps everyone, especially the insurance company. It saves them from paying out. You know, so I think if you negotiate perhaps a win-win situation with these people because they understand the economics perspective more, I suppose, that maybe there's a win for everyone, and they're doing that already in Korea. So they're doing amazing work there. The hypothermia acting is super important. That's why I was trying to highlight in the my slides where hypothermia helps. It helps in the changing the tumor microenvironment to change it from the Th2 dominant, like immuno tolerant, to like more Th1 dominant, where it starts to attack. It breaks down the tumor to release more antigens, so the tumor becomes more visible to the immune system. Helps to detox, so it helps on so many levels, you know, and especially if you get assistance in terms of patients being able to afford it. I mean, that's just the best way forward, you know. Even in Germany, only one hospital has insurance funding, just one. In Korea, the whole country.
No, actually, in India, you know, for the population we have, we can count the number of hypothermia machines on our fingertips.
Yeah, I know. I've struggled to get buy one because it's expensive, 200,000. You know, because patients have to pay a lot of money because the machines are expensive, right? And it's not covered by the government schemes or private healthcare schemes. But I think if I met a group of doctors in Indonesia who's trying to change that conversation as well, because I think the better group of people to speak to are insurance companies. If they can see that, especially in this exponential growth of cancer in the younger population. Now, most of my patients are not 70, 80 years old, right? Most of them are 30 to 50 years old with young kids who are used to be working, now not working.
Losing their most productive years.
Yes, correct. Yeah, and the insurance companies are losing their premiums, right? If they're not working, they're not getting the premiums. And if they die, then they have to pay out, right? So they probably potentially see the benefit of what we're doing, so to save them from losing their premiums and get payout. So I think anybody who wants to speak to this and at a high level talk about, you know, probably that's the best way forward in changing the scene, especially in the cancer care. You know?
I think it's been really nice talking to you, Dr. TAUFIQ, enlightening us on so many issues, including the last major one. Hopefully, I think we will see a change in the future in India as well.
Yeah, hopefully.
Insurance funded.
Integrative. Yeah, I think that's the way forward. It has to be, right?
Yes.
Because you cannot let the same situation, because otherwise the population, the economy as well. These are people who are supporting shouldering the economy of the nation. 30 to 50 years old, right? The working age groups.
Yes, absolutely.
If they so like you can see the impact downstream. The children are then orphaned and stuff, education. Your country will be decimated. Anyone's country will be decimated,
the
right?
state will pick up the tab anyway, in a different way. So in
different way,
if they bring in legislation, and if they bring in the right kind of attitude, then it will help in the long run.
So in this situation, we have to, because there's an epidemic of cancer, we have to work together and find ways of like win-win negotiations, in a sense. Try to see them, what's the advantage for them as well to get involved in this. Then maybe we can move forward.
Thank you. Thank you so much for your time today. It's been wonderful speaking to you.
Thank you so much, Karthikeyan. Thank you everyone for listening.
Thank you.